And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of the end. I will rise, we will rise, we will rise, we will rise up.
Hello, my name is Michelle Zabel and my pronouns are she and her. I'm an assistant dean at the University of Maryland School of Social Work and the proud director of the Institute for Innovation and Implementation. Today, I'm just delighted to welcome you to this Training Institute live workshop. As you might have come to expect with all your favorite conferences, the Training Institutes are now virtual. And although I know we'd all like to be together in person, we are excited to host the Virtual Training Institutes and really want to encourage you to continue to join us on the first Thursday of every month through August. Each month, you'll have a choice of 2 back-to-back workshops. So mark your calendars, choose your workshops, and make sure you reserve your place early so that you can attend the workshop that most interests you. Today, I want to encourage you to actively participate by using the chat to post your questions, post your comments, and share your resources with your colleagues. Our presenters, they definitely want to hear from you. And it is absolutely your participation that will make each of these sessions a success. As a reminder, staff are monitoring the chat and they're going to make sure the facilitators see your questions and comments, so be sure and engage. A few other reminders to include: if you need assistance at any time navigating through these virtual spaces or accessing links to workshops, we do have a live help desk support standing by to assist. We are also providing a certificate of attendance after the completion of each workshop, and all of our workshops are being recorded, so by you participating, you're implying consent. Finally, there will be an ASL interpreter or closed captioning available during each workshop. Those interpreters can be pinned when available for those who require interpretation by hovering over the interpreter's video and selecting the 3 dots. One of the options that will appear is Pin Video. By selecting the Pin Video, this video will not move out of view. Following the workshop, we will have a wellness and mindfulness break with guided activities before our second afternoon session. With our theme, What Could Be? Bolder Systems and Brighter Futures for Children, Youth, Young Adults, and Their Families, all of our sessions will challenge us to envision a future where the voices of children, youth, young adults, and their families are elevated, especially those who are most frequently silenced or marginalized, where we use the best data and research available to challenge ourselves, developing new ideas and approaches that can be implemented to meet the needs of youth and families, and in service of our commitment to social justice and the elimination of disproportionality and disparities. My hope is that today's session will provide you with food for thought as you consider your next steps in creating a vibrant, equitable future for youth with complex needs and their families. Please don't forget to register for next month's workshop. Remember, they're held the first Thursday of every month, and you can visit the institute.umaryland.edu for the full schedule. Thank you so much for joining us, and I look forward to seeing you next month.
Well, hello, everybody. Hopefully you can hear me and see the content here on the screen. So I'm Eric Bruns. I am a professor at the University of Washington here in Seattle. And it's great to be with you here from the department of my backyard office. I sure wish we could all be together. That video that Michelle showed before she came on really brought back memories of fantastic times that we've had in the training institutes. I think the first one I attended may very well have been in 1996. So we're missing those days, but they will come again. And in the meantime, kudos to University of Maryland and the Institute for putting together the TI Live, or the Training Institute's Live series. So again, a little bit more about me before I get into this content here today. I'm a senior advisor for the National TA Network and the Institute, and have been a longtime partner. I started my career at the University of Maryland, and in fact, I was the guy who hired Michelle once upon a time. So I can say that that might have been the best career move I ever made for the field of children's mental health. What has been built there at the Institute is extraordinary. So as a partner to the TA Network and the Institute, some of the things I do is co-direct the School Mental Health Assessment Research and Training Center here at the University of Washington, or the SMART Center. And before that, folks might know my work in wraparound care coordination. With Janet Walker, I co-direct the National Wraparound Initiative and University of Washington Wraparound Evaluation and Research team here. And these are going to be some of the experiences across schools, across wraparound, children's mental health that I'll be discussing or using as examples today on this topic of measurement at the state, system, and program levels. So as a way of getting into the content here, yeah, it's kind of interesting. So we're going to be talking today about all the ways in which implementation science dictates that we should be measuring and then using data from our measurement at these outer levels of implementation. Systems and states, organizations that are implementing evidence-based practices for children and families, the implementation support process that we do. But this is kind of ironic, perhaps a little bit, because a lot of folks may know me as the fidelity guy for wraparound in particular. And that's because when I started my career about 18 years ago in academia, 19 years ago there at the University of Maryland in Baltimore, my quest as an academic was something that was very personal and near and dear to my heart, which was to elevate the research base on wraparound. Wraparound at the time was really well known among families, family advocates, folks who advocated for moving towards more family-driven, community-based care, but there wasn't much of a research base. And one of the first things that I took on as an academic was working with my mentor, John Burchard, who passed in 2004, to define the wraparound practice model and then measures of wraparound practice. So what's interesting is that over the years, as we've continued this work in systems of care, we've come to appreciate that just measuring practice level fidelity only can get you so far in terms of actively shaping the systems of care and outcomes for kids and families. And so it's much more important, or at least equally so, to focus on the fiscal and policy context in systems, which dictates so much of what families experience, and what providers and organizations whose charge it is to better the lives or help families' lives. These are the kinds of factors that are going to be equally, if not more, influential on the outcomes that are experienced. And so now our National Wraparound Implementation Center focuses as much on measuring and then using those data to shape system level factors and wraparound provider organizations, community mental health centers, the factors that are at those levels as practice level fidelity. They're all important, as we'll learn, but these factors at the outer and inner context, these contextual factors, are incredibly critical. So that's a little bit about me. Let's do a quick poll. I really do encourage folks to use the chat box to put in comments and ask questions. I've got my great colleague here, Tony Bonadio, who's going to be looking at those questions and help us answer them. Go ahead and launch the poll. Who are you? Who's in the room right now? I'd love to find out. Are you a state level person? Are you an organizational or program leader? Are you a practitioner? Are you a family or youth run organization leader or a family or youth advocate? Are you a researcher or evaluator? Those are the 5 options, or there could also be other. We only have so many buttons you can push. So please let me know who's in the room. Let all of us know who's in the room. I'm very curious to see who would join on this topic today. And we'll give you a second to do that. One thing we didn't put in here is whether you might be someone at a center of excellence or an intermediary, which, as we've learned, is a critical role for making any kind of effective practice for children and families happen. All right, let's see what our results are. Really curious to see who's in the room. So we've got a lot of program leaders, managers, and supervisors, followed by a tie more or less for state level folks and researchers. We have some practitioners, some family or youth run folks, and then some other individuals. They very well might be some of those intermediary folks. All right, thank you so much. So let's get started here. Let me get back to my slides here. So what we're going to talk about today, we're going to start with a little bit of implementation science, not 101, more like 201. I think a lot of the folks in this room probably already know the basics of implementation science. So we're going to talk about how implementation science dictates the strategies and measures that we might use at the state, system, and program levels. And the examples I'm going to use are both wraparound as well as intensive home-based behavioral treatment. And we're going to talk about ways that these data can be used, because we don't want to just collect them for data's sake. We need to actually ask, why are we collecting them? What decisions are they going to influence? And what are we going to do with those data? So that's a little bit about what we're going to do today. And I'm going to go right to another poll. So we're going to be talking here about measurement and using data, primarily at those outer levels. Why are you here? Here are some options for you to pick the best option. Maybe none of these are great, but pick the best one. You're here because you're implementing a new program and you want it to succeed. You're here because you've been implementing something for years and you're trying to make it better using data and measurement. Maybe you're not looking to help a specific program or strategy, but just general information on this topic. Maybe you're a data or evaluation nerd and you just love hearing about research and measurement. Or maybe you're just not really sure and you're just here to be entertained. We'll try to make it interesting. So pick the best option. I'm very interested to hear, because these will relate to the content. All right, pick your best. Give you 3 more seconds. All right, let's see what people said. Why are folks in this room here today? So folks are really about midstream corrections right now. So we've been implementing a strategy for years and you're looking to make it better. And then some other folks are here just because they're into data and evaluation, which is great. I attend all sorts of presentations for that reason. Fewer folks are doing this from the beginning, and that's okay. There is no reason you can't take stock, just like we did at the National Wraparound Implementation Center all the time, and say, what is it we can do better around measurement? All right, very cool. So let's do a little bit of implementation science 101. How does it inform what we measure? So, some folks find this a little bit, problematic, but saying that implementation science is all about implementing EBPs or evidence-based programs. I would prefer to say that we're trying to figure out how to use strategies, not just programs, but strategies that work in our systems of care, peer support, wraparound, certain kinds of intensive home-based services, school mental health, whatever it is, we're trying to implement evidence-based strategies. And we know evidence-based strategies are informed by a lot of different things. Yes, research evidence is one of those things, but also we are asking our practitioners and our partners what has been helpful for the families that they work with, or the students. We need to bring that to bear as well. And we need to bring youth and family voice and preferences to the selection of what we do. Whatever it is that's the basis for your strategies, we want to use strategies that work. And yet we know that this is very challenging. We often have strategies in our systems of care that were selected because it seemed like a good idea at the time, or we are implementing things that others have asked us to implement without asking, why are we doing this and how are we getting all the support that's needed? And so we all love Dilbert. This may resonate for some of you. I'm back from the training. I got a big binder. The training is already forgotten, but the binder will last forever. A living monument to temporary knowledge. I've got a ton of those binders on my shelf, and I'm sad to say some of them are binders of information and training materials that I have put in front of people without asking, does this meet a clear need? Have we rallied folks to support the cause of using this strategy? Have we asked what the barriers are? So the implementation gap is all about what happens when we don't consider systems and organizational factors, when we decide to train and hope. That, in my mind, is a tragic kind of waste of resources. What was the first research to practice gap? Well, an example, lemon juice was shown to be effective in preventing scurvy in sailors in 1601, but it wasn't introduced into sailors' diets on ships until 1795. That is a 194-year research to practice gap. We need to narrow that gap, and one way in which we get research into practice is by asking what has to be in place at the system level and at our organization levels to get these strategies done. And measurement plays a role. But before we get to the measurement, use your chat. I'm going to have Tony help yell out some of the things that get put into the chat so I don't have to be distracted. I got enough issues trying to get all this technology to work. What gets in the way of effective implementation? Why is it that our best ideas don't actually happen in practice? Where does the research to practice gap, what causes it? Type some things in the chat, and hopefully we'll see some ideas from you all. What are the things, in a word or two, maybe three, that get in the way of putting our best ideas into practice in the real world for children, youth, and families? Tony, are you there? What are some things that are getting in there?
So budgetary money constraints, lack of time and capacity, adequate funding or lack of adequate funding and workforce, too busy for long-term planning. So really kind of dealing with the here and now, operating on old habits. It's complicated. It's a complicated thing to do.
Great stuff. Yeah, one thing, so money and time are a couple of the things we have to ask about before we do this, right? So do we have the fiscal, so here's a little bit of a, word cloud. So money, time, policies, they're all there, right? And then routines, rigidity. People say it's hard to break out of what you're already doing, right? It's hard to pay attention to the things that might actually be the most important of all if you really want to make this stuff happen. I would argue that it's better to not attempt a research-based strategy or a good idea if you are not attending to those very things. Do our staff have the training and support they need, the knowledge that they need, the time that's required? Let's not just train and hope. Let's take action on these levels and use measurement to help guide us. So great stuff. Yeah, one of the papers that we've written on implementation science and the question of the outer context and systems and policies is, if it's worth my time, I'll make the time. These are the kinds of things, for example, at an organizational level that leaders have to do, is to make it clear why this is worth the time of their providers. So this is all in quest of moving. In implementation science, our quest is to move from letting it happen, which is just diffusion. So diffusion just means you're putting information out there. Here's a research-based practice. Here's a manual. Here's some guidelines. Here's a training. That's just letting it happen. We're moving from that to dissemination, which would mean more purposeful, perhaps practice level support, where we're putting trainings out there and actually measuring fidelity or aiding in the understanding of the practitioners of how well they're doing. So we're doing more than just putting information out there. We're actually doing some work to help it happen by disseminating the information carefully. But what we really need to be doing is implementation, full-on implementation, which means making it happen, attending to the factors at the system level, the policy and finance level, the program level, the team level that will make these good ideas happen out there in the world. So that's what our quest is. And to facilitate implementation success, to make it happen, we need to put on an implementation headset, like this little dog here. So what are some of the things that get us into an implementation mindset that will help us think about what's needed to get good strategies implemented in the real world? Oftentimes, and in implementation science in particular, we start with frameworks. Challenges as in implementation science, there's over 100 unique conceptual frameworks and growing. There are so many frameworks out there that can be overwhelming, and people rightly, I think, say that implementation science is a kind of very esoteric, very kind of technocratic pursuit. It's about academia. But I think we can cut through all of that noise and really focus on a few key things that implementation science frameworks tell us that we need to pay attention to. Indeed, this is my favorite implementation science joke. Frameworks are like toothbrushes. Why are frameworks like toothbrushes? Well, it's because everyone has one and nobody wants to use anybody else's. There are so many implementation frameworks. I was recently learned that the Institute that hosts the National TA Network and these training institutes is developing its own implementation framework. That's all good. Make whatever works for you. But when it comes to the big picture here of measurement and staying on track, there's a few things that we can take home from 100+ frameworks that have been found in the literature. One thing, as the title of this presentation suggests, implementation is multi-level. So to get to practice, we need to think about the programs and the teams that are within the organizations, that are within the systems that might influence what goes on in that interaction between practitioner and family. So implementation is multi-level is the first thing to be considering as you put on your implementation headset. Implementation has discrete phases, okay? So let's ask where we're at in the process of implementing something and use measurement strategically to inform the kinds of decisions that will happen at different phases of the implementation effort. Most of you say that you want to improve something that's already going on. So that's cool, but think to yourself, are we rebooting that strategy? Could we conceive that maybe we're actually in a pre-implementation of new approaches to getting this done? Or are you in the middle of implementation and you're trying to improve what you're currently doing? These are kinds of things we'll talk about in a sec. Third, there are consistent domains that we need to pay attention to from all these frameworks. There's certain things that we should be asking about and measuring. And finally, like I said, to decide what to measure, start with a framework that works for you and use it to help keep yourself on track about your strategies to support implementation success. So our first point, implementation is multi-level. This was one of the first kind of implementation science frameworks. Of course, frameworks for implementing things go back many, many more decades than what implementation science likes to think. It was, invented implementation in the, 2000s. That's clearly not the case. People have been thinking about policy, been thinking about what makes trainings and other kinds of supports happen for decades, right? But one of the first kind of pure implementation science frameworks was by Shortell. And this is in, she was thinking about the medical system in particular, but she conceived of it as 4 levels of change for assessing performance improvement. So first, at the larger system or environment level, the things we need to pay attention to there, as people pointed out in the little word cloud or the chat box, reimbursement. What are the rules for reimbursing for the service? What are the laws about what needs to be attended to in implementing services? Policies. What are the regulatory policies? What kind of degrees do people need to have? What kinds of training is required? What kinds of licenses? So regulatory policies. Is there value-based payment going on in the system? So all those kinds of issues. At the next level, again, got the organization. What kind of structures do we have in our organization? Do we have learning communities? In what kind of context do our supervisors give feedback to our practitioners? What are the strategies that we're using to incentivize implementing the things we want to implement? Those are program and organizational level decisions, and we can't take them for granted. They have to be attended to, like every day. Then you've got groups and teams of practitioners working together, like a unit that might be doing wraparound care coordination. What are the strategies that we would use to bring those folks together to coordinate and cooperate and learn together? Are we going to do group supervision? Are we going to have learning communities in which folks are looking at data about their practice together? Do you have a shared vision that really drives you and makes your job worthwhile? Do you have incentives for collectively learning from one another? Do you have peer learning and so forth? And then finally, of course, you've got the individual practitioner. All of these things are going to shape their knowledge, their skills, and their expertise, which are the key assumptions about how well it's going to go at that level. So implementation is multi-level. Implementation, second point, is also multi-phase. So here you can see from Greg Aaron's EPIS framework: exploration, preparation, implementation, and sustainment. Everybody's got their own version of these phases, but this is the way the EPIS framework puts it out there. What are some of the things that you might collect? So starting to think about data. What are some of the things that you might collect in terms of data at the exploration phase? Well, you might be collecting information about what's the fit between the proposed EBP and the current context in our system, or what is it that's needed in this system? Do we have too many kids in institutional care? Do we have a huge gap in our community-based continuum of care around peer support? Or do we have a gap in terms of certain kinds of evidence-based practices, not enough folks trained on effective behavior training for parents? So evaluating the need or the fit between what currently is going on and what might be some strategies is a measurement undertaking at the exploration phase, and assessing the system level and the program level factors that might influence whether a proposed EBP would work. So you should collect those kinds of data to make sure that you can make good decisions about whether to adopt something. Talk to your providers, talk to your families, look at your costs data, look at your out-of-home placement data, look at your service array and ask where the gaps are. You can do these things systematically in the exploration phase. So you've made an adoption decision. All right, we really need to expand wraparound because we have too many kids going out of home, and we looked at our data and a lot of them seem like they could be supported in their community. So now what kind of data might you collect at the preparation phase? We could collect data about what stakeholders believe is needed and what their reaction to this idea might be. We could systematically ask for whatever the proposed EBP is. What are the things at the system and fiscal level that need to be in place? And for wraparound, we have a specific tool for that I'll talk about. Other EBPs have their own. So address and ask about the outer context and inner context and whether or not we need to, what we need to address to make it possible to implement this thing. Do those things before you get to implementation, before you ever bring people together for a training, please. So then you do your training and coaching because you've set up for success at those levels. Now you're in implementation. What's kind of data that you're going to collect at the system level, at the program level? You're going to be collecting data ongoing about the degree of support that exists among the system leaders, the sector leaders about this EBP. You're going to ask them what is and isn't working for them so that you can anticipate those needs so that support for this thing doesn't go away. And you're going to be continually problem solving and improving at the system and program level. And again, I can't emphasize this enough, there are systematic ways to measure that. It's not just an art. And then finally, to get to sustainment, you're delivering this EBP with fidelity because you've worked out the system and program issues And now you've got good support, good fidelity, and to sustain, you want to continue to collect quality assurance data on that EBP to make sure you don't get off track. You're going to be collecting data about whether or not individual practitioners have their contingencies being managed. So are we reducing turnover? Are we giving them good supervision, giving them good support? That's the kind of data that you might collect in the sustainment phase. So I'm talking real generally now, but we're going to get into some details about kinds of measures that might work at those levels in a minute. But first, another poll. So let's see, we're half an hour in here. How many folks are still with us? I want to find out. So think about the strategy. A good number of you said there's a strategy you're starting or trying to improve that you want to apply implementation science to. So what phase of implementation are you most interested in measuring supporting, possibly measuring? Do you feel like you're at pre-implementation? Are you at planning and preparation? Are you in implementation? Are you in sustainment? Think about the thing that the program or strategy that's most on your mind and pick which one of those. I think we might have gotten to poll results too quickly there. There we go. So here's your poll. Pick which phase of implementation, the strategy you're most interested in today. What phase of implementation you're in. Might need to get some more water. All right, even if you're just guessing or guesstimating where you're at, pick one of those and let's see where people are at. All right, go ahead. What kind of results do we have here? Oh, I don't see any results. There we go. All right, so folks are largely in implementation, but it looks like some folks are also in planning and pre-implementation. In fact, more folks are in pre-implementation and planning than implementation. So that's cool. That means that you've got an opportunity to collect data to inform your decisions about how you're going to do this, as well as implementation and sustainment. So it's really interesting. So we're distributed across all of these. So we don't want to pay any more attention to any of our phases than any others, it looks like. All right, cool. So last point I made as a setup here is that implementation has a manageable number and kind of set of domains that we need to pay attention to and that we need to actually measure. And this is coming from the Consolidated Framework for Implementation Research, or the CFIR, that was developed by Damschroeder and her colleagues. So we know that there's hundreds of frameworks in implementation science. The CFIR attempts to bring them all into one kind of overarching model. And we created our own version of it just to make it easier to summarize. So apologies to Laura Damschroeder and her colleagues for butchering it and turning it into this version, but this gets to the basics. So if you want to get to outcomes using evidence-based strategies, that's always your ultimate goal. So you have that at the far right-hand side of your logic model. And to get there, you need the supports that you're trying to provide those youth and families to actually succeed. So what represents success? Implementation success, high quality, high fidelity practice are all things that are important. But also important both to get to fidelity and implementation success, as well as straight to outcomes, is what kind of people are actually providing this service? What kind of people are serving our youth and families? You know, how dedicated are they? How value-based? How skilled are they? How committed? All of those things are important. How long are they going to stick with this job? The other thing that's real important in this inner kind of inside the box is the intervention or strategy itself. We often don't ask carefully enough, is this strategy actually feasible? Is it doable? Is it acceptable to those who are going to do it and those who are going to receive it? Those are a couple of things that are critical to getting to implementation success as well as outcomes. But what is it that influences all of this? Again, the inner context or the organizational level factors, and then the outer context. Those are fancy terms for systems and programs, right? The outer context, the fiscal and policy context, and the inner context, or what's going on in an organization like a community mental health center or other organization that's doing this work. It could be a family-run organization or youth-run organization. The last thing that gets probably the least amount of attention in terms of measurement is then you've got the implementation process. So something that's trying to take those people and that intervention, consider the inner and outer context, and actually support implementation so that we're making it happen. There's more and more of those kind of intermediary organizations out there doing this work, like the Institute at the University of Maryland. So we have to ask about not just program systems, but also how is the process of supporting the people to do these strategies going? And we can measure that as well. So basically 6 things on the implementation side: fidelity, individuals, intervention, organization, system, and then the implementation process. Reasonably doable. So here are the same things in words, right? So according to the Consolidated Framework for Implementation Research, the CFIR, that outer setting is about, again, policies, funding availability, funding rules, collaboration, right? This is one of the reasons that from the very beginning, systems of care said you need to have a community, cross-sector community entity that's overseeing implementation of systems of care. Because if you don't have collaboration among your child-serving organizations, and that also has youth and families in there to shape the decisions, you're not going to be as likely to succeed. So that's the outer setting. Inner setting, organizational culture and climate. Do people want to go do this work every day? Are they adequately paid? Do they get reinforced for doing a good job? Are they trained and supervised so they feel competent? These are the things we attend to at the organization level. I was talking about the intervention. We often don't pay enough attention to it. Is this and all the things that a practitioner is being asked to do feasible? Or is it too much? Is it too complex for the amount of time they have? Is the intervention or strategy adaptable to the local context? That's important as well, because there is no implementation without adaptation. You got to stop pretending that adaptation is something that takes us away from the pure heart of an EBP. There is no implementation without adaptation. It's just a question of whether it is capable of being adapted to the local context in a way that doesn't dilute it or take away the core things that work about it. And then, like I said, individual characteristics, knowledge and beliefs, education, do they feel self-efficacious? And then finally, that implementation process, not as often attended to in research until relatively recently. But are the activities we're undertaking to get something done happening the way we want them to? The planning, the executing, the evaluating of the process of getting something done. We can look at that as well. All right, another poll. Take your best guess. What implementation support factors among these do you think is most important to whatever program you're thinking about right now? What factor might you be most interested in measuring? And then, of course, acting on? Would it be the system level or the outer setting? Is it an organizational level, which could be a bunch of organizations, or maybe it's just yours? Is it about the strategy itself? Is it about your practitioners? Or is it about the implementation process? Like the process of getting ready, doing training and coaching, installing structures? What thing do you think, based on the best information you have, that you would most want to measure right now if you had that opportunity? Pick one of those, and let's see what folks say. These polls are good. Give me a chance to drink some coffee. Thanks to our wonderful interpreters for being here today, by the way. All right, let's see what people said here. Oh, interesting. So people are really interested in the implementation process. So we'll have a great tool to share with you about that. Not surprisingly, people are less interested perhaps in measuring individuals. They probably feel like they kind of know the deal there. But looking at organizational factors, intervention factors, that's cool. Talk a little bit about that. And the process are the primary things that people have said. That's cool. All right, that's a little bit surprising. I like it. All right, we'll talk about a measure of the implementation stages in a little bit. So I'm going to pause. Tony, any good questions to throw out there to me, to yourself, before we get to some examples of measures at those levels?
We don't have a ton of questions right now, so why don't we keep going, and I have some questions that I'd like to hear you speak on, but we'll save those for the end.
Okay, sounds good. I saw a few things in the text in the chat click, but I'm not looking at it actively. So alert me if there's anything I need to know. Maybe someone's telling me that, I don't know, my background is distracting or something. Not much I can do about that. All right, so let's get to some examples of measures. We've talked about the levels. We've talked about the domains we might pay attention to. Let's talk about some of the measures. And Tony, who's here with me, he is intimately familiar with measurement of all of these different factors for wraparound. He has been one of those people who is making it happen in a few of our states for the National Wraparound Implementation Center. So the National Wraparound, so NWIC, as we like to call it, measures those CFIR constructs. So what are some examples of ways we measure these things? So start with just the characteristics of the intervention, but it's the interaction here I want to talk about between the team or the individuals and the characteristics of the strategy. So these are some things that we measure very assiduously. So certainly, even though we're also paying attention to the outer and inner context, we are training and coaching. So when we train and coach our practitioners, our care coordinators, our youth and family peer support partners, we ask them for their immediate feedback and then follow up with them about what has your ability been to use the skills we trained you on. So we ask them immediately after our training events, of which there are many, what is your anticipated use of what you've learned? And then 1-2 months later, we ping them again and say, what have been the barriers to using the things you learned? How much have you been able to use these things? So that we can learn about, again, that interaction between the practitioners and the model that we're training them on. Because this gives us a lot of information about the fit of this EBP and their program and system. So we asked, so this is focusing not just on the quality of the training and how much they liked it, but how much they feel as though this is going to fit with what they do. And then a big one we use is, this is not a fidelity tool per se. It is the coaching observation measure for effective teams, the COMET. So this is something that supervisors and coaches use to assess our wraparound practitioners, our care coordinators, their mastery of the skills that they need. So they train local coaches. First, our coaches do it, and then they train local coaches to do it so that we leave the expertise behind to score what kind of skills and what level of skillful practice is going on the things that need to get done to implement wraparound. So it's a quasi-fidelity measure, but it's also a coaching measure. It's about skill achievement. All right, so those are some examples. There are many others that exist that we'll talk about at the team and individual level. Just giving you some examples first off here. Things that keep us on track at these different domains. So how about fidelity, right? So we're training and coaching folks. We're measuring their skill attainment. When you get to implementation and sustainment, we're asking about how well is this getting done in your actual systems of care? And I'll bet a good number of you are familiar with our wraparound fidelity assessment system tools. So we have interviews and surveys, we have observations, we have chart reviews, this very cool document assessment and review tool, and we have program and system level assessments that, whether it's about midstream correction or ongoing sustainment, asks how well is the system and program, or the system and program, set up to support wraparound. So we have measures of implementation success and fidelity that leverage multiple kinds of measurement strategies or approaches. Not going to dwell on these, just using them as examples from the wraparound context. So that's over there in fidelity. How about the topic that we're really here to talk about, programs and systems? So this is, again, something that we realized some years ago. We have got to come up with measures for programs and systems. Wraparound provider organizations and how well they are set up to support high quality practice and outcomes, and then state system level measures. So what are the NWIC tools to assess context and implementation progress at these levels, these difficult to address organizational and system levels? So a couple things. The outer context, that blue box at the top, we have the wraparound implementation standards. At the system level, we have asked, what are the things that need to be in place in our states and our systems? And we have not just an assessment of those things, but something that's used for active coaching. We're not just coaching practitioners, we're coaching the system leaders, right? Or for the inner context, the wraparound implementation standards program tool. So we got to come up with some better acronyms, because we always get confused when we're just talking at each other. The WIS, have we done a WIS? Have you done the WISP? The WISP, the WIS, sounds like the same thing, right? So sometimes we say the WISP just so we know what the heck we're talking about. The reason we're talking about them so much is we collect these data for every state or site that we're providing training and TA to. The last thing here is the wraparound stages of implementation completion. So this is based on the stages of implementation completion measure by Lisa Saldana, but it's been customized for wraparound and the types of things that NWIC does. So let's talk about each of these tools here. So the WIS and the WISP are completed through a survey process that's facilitated by one of our national coaches. So they do this in ongoing basis, like every 6 months, with the wraparound provider organizations for the program and with system level leaders for the system level tool. And it may require multiple sessions to gather the needed information, but that's okay, because that's what we do, monthly or more frequently if needed, coaching and technical assistance conversations with organizational and program leaders and system leaders. So why are we doing this? Let's back up for a sec. We know that outcomes and fidelity are highly dependent on program and system factors. Let's just give you some examples of things that we have to ask. We ask this at the beginning, we ask it ongoing, we ask it during sustainment. Or I should say that during sustainment, local coaches are going to be asking this. We are out of the picture by then. So let's ask about eligibility. Do we have a clearly defined population of focus? Is it the right population of focus? How about funding? What is the mechanism to pay for this? We know that in wraparound, per person per month or case rates are much more effective. We know this now because we have these data and we see whether these factors here affect outcomes, and they do. If you have case rates so that you can do flexible plans of care, you're going to succeed and get better fidelity and better outcomes. So we ask that question. Are we moving towards fiscal mechanisms that will get you to use case rates? And is that rate the right rate? How about our staffing ratios? That's a system level issue as well as a program level issue. Both of them are going to influence. We know that the standards we have is about 1 care coordinator to every 10 youth and 1 supervisor for every 4 staff. Ideally, for workforce development, we also have unique units just focused on care coordination. And we're not asking folks who are doing care coordination to do that on top of their therapy or their other duties. So all of these things are asked systematically in our system and program tools, the WIS and the WIS-P. Finally, system policies. Do we have flexible work hours? This is organizational policies too. But at a system level, is there something that's been agreed upon among the child serving sectors that says the wraparound plan is the plan we use, regardless of how many systems the kid is involved in? The wraparound plan is what drives the family's experience. Is that in place? Is that something that the system leaders across child welfare, juvenile justice, mental health have agreed to do or not? You got to move towards it if not, if you want to get to the best outcomes. So how do we then measure these things that are in our book of implementation and practice quality standards? So it's got old logos from NWIC and the TA network because it was way back in 2016, but we defined the implementation and practice quality standards. Just Google it, just put in Jennifer Coldiron, who is the lead author, miss her greatly, and wraparound standards, and you'll find this on the web. Maybe Tony can put it in the chat box. But these standards are the foundation for what we measure in NWIC. They're grounded in both implementation science and wraparound and systems of care. And so there's 7 implementation related areas and 43 indicators that can be used as a self-assessment and to monitor quality throughout your implementation process. And it's these standards that we based our WIS and our WIS-P on. But if you're not getting NWIC support, just go find this document and self-assess. How are we doing on in these areas? So one way that you can do this is by a comprehensive process that our team has facilitated called the Wraparound Structured Assessment and Review process. So asking how well these standards are holding up in your system of care. We're asking about your family and youth outcomes. Do you have evidence that you're getting the right sized help to families and that you're not unnecessarily placing too many kids out of home and community? Do you have wraparound fidelity? So we sample some families and administer the wraparound fidelity index. And we get some videos of some team meetings and we review them. So we ask about your fidelity. And then, like I said, this is all informed by implementation science. We know that fidelity and outcomes are driven by staff competency, program or organization drivers, and leadership. And all of that is influenced by the community and system. Again, different framework. This is the NERN framework, but the same concept. Systems, programs, staff get you to outcomes. So I'm not going to get too much into this, but if anyone wants a systematic, structured review using our tools, you get this by being an NWIC, a state that gets support from NWIC, or those of us here at the Wraparound Evaluation Research Team at University of Washington can go through this process using similar tools. And it will get you data across those 7 drivers that I was talking about, or 7 domains that are in the wraparound standards: outcomes, fidelity, implementation, including organizational, leadership and competency, and then system. Again, the same domains keep coming up: outcomes, fidelity, systems, programs, and staff. All right, so that's a little bit of getting in the weeds. Let's get back to measures of system and program that NWIC uses. So here are our coaching and continuous quality improvement tools for wraparound implementation used by National Wraparound Implementation Center. I already referenced them. There's the WIS, or the Wraparound Implementation Standards, system level, and there's the WIS-P, Wraparound Implementation Standards program level. So now this is not a let's check on how well you're doing across all of the standards. This is about coaching, ongoing collection of data about your readiness to implement wraparound at a program level and at a system level. And again, Tony is intimately familiar with these. He's validating them as we speak and trying to help them become measures that the field can use for different contexts. But day to day, we use the system level standards assessment to help provide training and coaching to our system leaders that have requested our help for wraparound. Here are some examples of the domains. Again, remember, implementation happens in phases. So for the system level, wait, are we at the system level? Yeah, system level tool is organizing its indicators by pre-implementation, implementation, and sustainability. And we're trying to get there in 18 months. But if we don't, that's all right, just keep assessing. So we're asking questions at the leadership level. Are there standards at the system level for what the organizations that are implementing wraparound, how they're structured, right? So we have standards for organizational level implementation teams. Are there implementation teams that include the right people at the organization level? Does the system dictate that that will happen? Does the system say that there's going to be data and feedback loops? The system leadership provides guidance for a process to support Medicaid application for eligible referrals. We're really getting in the weeds here, folks, because this is all specific to wraparound and systems of care now. This is not just general high level. This is stuff we're training and coaching system leaders on. And if you're not living up to these things, we come up with a plan to get them in place. So then once you get to implementation, we have items that are more relevant to that phase, right? And then sustainability. By the time you get to sustainability, you're asking, do we have continuous quality improvement infrastructure in place? Are we measuring the percentage of youth that we serve going to out of home, right? So you've got accountability mechanisms in place by the time you get to sustainability. But when you're in pre-implementation with us, we're asking these things in the red column and asking if they're in place before we even do implementation. So example indicators at the system level, just gave you some, here's some more. Executive leadership has designated appropriate staff with authority to lead a cross-systems initiative and manage the implementation, right? You could probably succeed at a state level without that, but it's not going to be as likely, and it's probably not going to be sustained. So we're coaching folks based on the presence or absence of that measurable support. System leadership identifies financing streams to support workforce development. IT, are those things in place? Are they sustainable? If they're not, let's work on that before we start training your staff. And then at the sustainment phase, we're asking if you're seeing and can measure and can dictate and document that the kids you're serving are increasingly likely to stay at home. Then at the program level, let's get into every wraparound provider organization that a state is standing up to implement wraparound and ask each of them, ask these things of each wraparound provider organization. Do you have an implementation team? Does the provider organization plan for sustainability by asking whether or not what the implementation costs are and if they're getting enough funding to make it sustainable? And then we get to sustainment. Are we indeed achieving fewer than 20% out-of-home placements per year and hopefully improving from there? So again, there are ways, whatever your program is, to think about system and program level factors and ask whether they're in place or not. And for NWIC, we have reports that we use both for our research, but also for coaching. At an organization level, as you can see here is an example of aggregate report across these domains and over time. How are we doing at achieving these things? So what percent of the many sites in a state in this example are actually achieving our criteria for defining the appropriate population, for having accountability mechanisms in place, for having no wrong door access, services and supports, and so forth. All right. Anything you want to throw in there, Tony, while I take a drink of water?
Yeah, so we did have a question come up. Folks were wondering if you could offer any insights about how people may better understand EBPs or evidence-based strategies in terms of their relation to unique organizational cultures. So they give the example of how an EBP with fidelity requirements that involves a great deal of paperwork might not fit well for an organization where paperwork is perceived by the staff as an undue burden.
Well, I think you kind of answered your question, right? So to some extent, if we're zooming out away from a specific EBP like Wraparound and talking about the world of possible strategies you would use, I think the important thing is to go back to kind of the concepts at the beginning and ask, what are the things that we know drive success? And fit, just like the CFIR here says, fit between the individuals or the teams and the characteristics of the intervention is really critical. And there's no magic tool for answering that question that I know, although there probably are. Well, I'm actually, that's not true. So there are measures such as the evidence-based practice attitude scale that you can administer your staff and ask them systematically what their kind of predisposition is for manualized EBPs, which is the example you're giving. So you could administer a tool like that and see if your staff, hopefully answering honestly and anonymously, fall above or below kind of an average score for attitudes or predispositions about evidence-based practices. I know that's not getting exactly what you're talking about, but that's part of it, I think. But then the other thing is just do exactly what you just kind of insinuated. Talk to your staff before you start proclaiming that you're going to implement something. Review the characteristics of the strategy, just like this CFIR suggests, and say, does this align? Right? Bring a leadership group together or some, cross sector of your providers and have them kick the tires and ask about what would be the barriers here. I mean, it's just amazing to me how often we do train and hope, and I've been guilty of it. We don't talk to the people who would have to implement it. We don't ask about the system or program barriers that need to be addressed before we do it. And I think the point is that these are questions that you have to ask. And there are some standardized measures of these things. You can assess your organizational climate in general. There are measures of leadership, evidence-based practice leadership that are out there that Greg Ahrens has developed. So you could be assessing the supervisors in an organization to see if they're predisposed to champion these kinds of things. You can do the evidence-based practice attitude scale. But in the end, regardless of whether you use those kind of more research-based standardized assessments or you just do a needs sensing, the point is to use this kind of framework and ask those questions. I don't know, Tony, you got any other thoughts on that one?
No, I think that's really bringing in those stakeholders, so staff and even families in the community who may be served by whatever EBP is under consideration, to really have some folks kind of identify those barriers to and help in that assessment of fit process.
Yep, I would agree. All right, so good question. So there are standardized measures of those things. And if you want to email me afterwards, I can help point you to them. But I think a lot of it is just putting this headset on and asking these questions very carefully and in some way or another systematically. So last domain to talk about that actually a lot of folks were really interested in was implementation process. What do we do in Wraparound? We spent some time working with a really brilliant woman named Lisa Saldana, who some years ago created an implementation completion measure. So this is something that's universal. It's not EBP specific. The SIC, or Stages of Implementation Completion Measure, assesses 8 stages of implementation process that are fairly generalizable to just about any strategy or program. So here's a little picture, and you can see that there are 3 phases. Again, this is what we based the NWIC, WIS, and WIS-P on. Pre-implementation, so 3 stages: engagement, feasibility, and readiness planning. right? And the things you got to do during those phases are there in the subscripts. Learn and decide, review expectations and capacity, just like the question. You got to ask these questions of feasibility before you decide to implement. And then you prepare to implement, but not until you've engaged and assessed feasibility. Then you get to implementation. You're doing staff hiring, you're doing fidelity monitoring, you're doing consultation, and then ongoing services where you're supporting and monitoring. So implementation has multiple stages. And then finally, you get to competency, which is the sustainment phase. We all hope that we've got competent staff and that turnover is not so bad that it is wrecking your good work, right? So running out of time a little bit here. Let's kind of get through the SIC here, but again, 8 stages across 3 phases. Pretty much what I just went through. And there's a universal SIC, or stages of implementation completion measure, that anybody can use by, I would just, Google, sorry, I don't have the website here. Maybe Tony can find it and put it in the chat, but stages of implementation, you sign up to use it. And what's really cool is that they have a web-based system where you put in how well your program or your implementation effort is doing, and it will feed back data to you, showing you where you're at. And so here's an example. It's a little clunky, but kind of cool. So you see here, there's multiple programs, and it's showing you how fully your implementation is going in terms of how long it's taking to get to through each stage, and the proportion of activities completed. So in there, you see those little boxes. Those are steps in the implementation process across the 3 phases. And it gives you scores, and it can kind of help you compare how you're doing compared to other EBPs or other teams that are implementing EBPs. Pretty cool. Okay, so that's the implementation process. So now we've given you all these examples about wraparound. So again, outcomes, we're looking at residential functioning in school. Whatever you do, please, I learned this the hard way with fidelity. People started measuring fidelity and were all about it and forgot to measure outcomes or didn't deploy resources to measure outcomes. You've got first and foremost to know whether or not your kids are in school, at home, and out of trouble, right? Or some version of that. We talked about our fidelity and implementation success. These are just some examples, our wraparound fidelity index, the TOM and the DART. Talked about asking your staff how well this is working for them, assessing their skill development. We have our implementation standards that have specific items at the system and the program level. And then the SIC is a very cool example of a way to ask, how is your implementation process going? All right, one more quick example. Intensive in-home behavioral health treatment. And some other things to measure. Another example of something and some things that we created to try to measure, not an evidence-based manualized version of in-home behavioral treatment like MST or FFT, but the more generic form that exists out there in states. So background, intensive home-based treatment is a critical service in children's systems of care, but few states have any kind of systematic CQI system for their in-home behavioral health treatment. And so we know, again, that just like for other programs, for in-home behavioral health, outcomes are influenced by both structure and process. So you can do this for programs that you might have that are homegrown. What are the standards that you're looking to achieve in terms of the program and the practice? And so we created, with the help of a bunch of smart people in-home behavioral health, Joe Woolston, Rick Shepler, Kelly English, program standards, conditions at the level of organizational program or service system, and practice level standards. So what are the activities or techniques that are expected of practitioners that are from the research base on what represents effective intensive in-home behavioral health treatment? So This was funded by the National TA Network through SAMHSA. And what we did was we undertook 4 steps, which again, this is something that you all could do for your own homegrown programs. We did a literature review. What does the literature say promotes effective implementation of intensive in-home services and keeping kids in their homes and communities? What are the things that have been found in research? There wasn't a ton out there, but we did distill that literature down, did some expert interviews with some of the developers of our evidence-based home-based treatments, state folks who have used in-home. We said, okay, what would be standards at a program level and practice level that would be generic enough to be able to be used by these large state-level in-home behavioral health programs that exist out there? And so we developed some initial standards, 49 practice standards and 30 program standards. And we did a systematic Delphi process, which means we sent these to over 70 experts in the field and state leaders and said, tell us about your response to these first draft program and practice level standards. Give us feedback on how important each standard is and the current wording and how we could revise them to be clearer. So again, this is just another example for another type of service, and really just looking at those 2 pieces, which is the practice fidelity and program. And so here we created these, and we just got this paper accepted. So intensive in-home behavioral health treatment, example of program standards. Again, there's 30 of them, and they fall across about 7 categories. So within the competent staff category, some standards that dictate what kind of credentials the practitioners should have, standards for maintaining a stable workforce, so keeping turnover down. What kind of hiring processes does your program have? Do you adhere to this standard that says you have written interviewing and hiring protocols for all the relevant positions in your in-home program? Effective training. So this is just 6 out of 30. Then practice standards. It's just like what we did to some extent with Wraparound way back in the day. But for in-home behavioral health, we were looking at creating these standards for practice level fidelity across categories like engagement of families, cultural competence, risk identification, safety planning, crisis response, right? So some things to keep you on track. And so running out of time a little bit, but again, here's examples of standards at the practice level. Service coordination. In situations where there is no care coordination or program or provider, the in-home behavioral health treatment provider integrates case or care management into the practice model. 24/7 availability. Crisis response is available at all times. Do you conform to that standard at a program level? Commitment to flexibility and accessibility. Again, do you conform, or if you're in the pre-implementation phase, asking these questions, are these things feasible for the programs that you're going to try to invest in to do in-home behavioral health treatment, right? Comprehensiveness of intervention. Some IIBHT teams have multiple team members, but regardless of how many team members there are, will someone be able to cover this full array of needed skills? Behavioral management training, individual therapy, family therapy, 24/7 crisis response, so forth, safety planning. Small caseloads. Let's ask this question. If you're in pre-implementation, is this doable with your reimbursement rate? Number of youth and caregivers per practitioner is appropriate to the practice model. Ideally, 6-to-1 for a 1-person team, 8-to-1 for a 2-person team, 12-to-1 for a 3-person team. So how do you use these, right? So again, Put on your implementation science headset. Put these standards in front of your system leaders, your managed care entities. Can you develop rules and your MOUs and your contracts when you are purchasing this type of care? Can you build these directly into your contracts? Can you fund this? What kind of investments are needed in professional development when you think about having to achieve these standards? And then, of course, evaluating going forward how close we are to achieving them. Provider organizations can use these standards to ask how well are their teams that are implementing IIBHT doing. You can use these data to continually improve using plan, do, study, act cycles. Practitioners can have these at hand to help them with onboarding, ask what their expectations are at a practice level. So, wrapping up on this example, we have a program level quality assessment now. So the standards are great. They can inform a lot of those kind of implementation processes. But when it comes to measurement, we need a reliable and valid measure of the degree to which a program or a practitioner is achieving these standards. So we created, based on a great example from my colleague Betsy Farmer for treatment foster care, we created an interview with intensive behavioral health treatment agency representatives to find out how closely they're conforming to these standards. So it's a semi-structured interview. And as you do this interview, which in our experience thus far can take an hour or a little bit more, you code out what the agency representative is telling you about, for example, safety planning. And you ask them, how do you do safety planning? You code the answer to this standard. Is there indeed safety plans that are completed collaboratively with the youth and caregiver that actually assess safety concerns, triggers? Does it include natural supports that would be included in the safety plan, right? So it's got a way of coding all of the pieces of the standard out. So anyways, this is just an example of how a measure of program standards such as this might be undertaken just by doing an interview with an organizational or program leader. And then you can create, get you scores. Okay, so almost out of time. Point here is just like with the wraparound measures, we would want a state in-home behavioral health treatment initiative to actually use these data. So before you decided to launch an IIBHT quality improvement effort, you might ask about the current fit between your providers and their capacity to do this kind of evidence-based in-home behavioral health. So you might administer that measure or have them self-assess. You can also use them to then tell legislators and stakeholders where the gap is between current practice or current program characteristics and what's needed, and say, assess the fit, assess the feasibility of doing this, or ask, do we need more money for these providers? Better reimbursement rate. We need to stand up a center of excellence. Look at the data. It's clear that they're not there. We need to get there. During implementation, you can do plan, do, study, act cycles using these data. You could use it to support value-based purchasing. So those programs that actually achieve these standards get an enhanced rate because, one, it's expensive to achieve these standards, and two, you want to reinforce good practice. All right, so plan, do, study, act cycles and all those things are just a few implementation strategies that can be informed by your measures. So wrapping up here, use data to decide what implementation strategies you're going to use to get an evidence-based program or strategy done. And so thinking about how to use your data, it's all in service of asking what kind of supports are you going to provide to implementation. So there's a ton of implementation strategies available out there. And if you break them down into some categories, Some of those implementation strategies include educate your stakeholders, look at your financing, doing planning in a collaborative structure or learning community. An implementation strategy might be about restructuring a program or an organization. So alter staffing, physical structures, IT, data tracking. Quality management is a fifth implementation strategy category. So collecting data and feeding it back. And then finally, just like those examples I was giving you for wraparound, attending to the policy context, huge. What are the things that need to be in place at the system level? Are we actually achieving those things? So the point here is, if you put on an implementation headset, there's all sorts of strategies that you can ask, do we need to leverage these things to get what we want to get done? Skipping this for now and getting to the last point. How important are these things, program and system factors? Our research says a lot. And again, Tony knows all about this. So we presented this at the NIH Dissemination and Implementation in Health Conference. We asked, using our tools in wraparound, how much does it matter what the outer context, the system is set up? Different states have different approaches. Care management entities versus community mental health centers. Care management entities are centralized locus of accountability for wraparound delivery. So these entities like Wraparound Milwaukee, they're just focused on doing care coordination for kids and families. They're not doing a whole bunch of other things like community mental health centers. They have their own, they can contract themselves individually with programs and practitioners out there to get the service array done for these kids that they're responsible for. And they usually get a case rate to do it. Whereas community mental health centers, when states use community mental health centers to do wraparound, usually they don't have a specialized unit. They often are getting fee for service. So very different policy and finance structures. And so the example from Wraparound Milwaukee, all of these different systems are putting money into the care management entity, Wraparound Milwaukee, which is contracting with Families United, which is contracting with 210 providers themselves and measuring their quality. And they're the ones responsible for the full and complete and holistic care for kids across all of these systems that have complex needs. So how much does it matter to fidelity and outcomes, whether a state uses care management entities like Wraparound Milwaukee or does fee-for-service community mental health? Bottom line is, we were able to use our measures of implementation progress using the SIC, of implementation fidelity and skill attainment using the COMET, and using training impact using the IOTA, all these measures that I've already referenced. And what we found was that the states that had the more conducive policy context, the CME states, on the SIC, they completed more of those implementation tasks in the SIC successfully. That's the light blue bars versus the dark blue for states that are organized to deliver wraparound with CMHCs. We found using the SIC that the CME states in orange got to implementation completion much quicker than those that used community mental health centers. And if you're really interested in looking at SIC data, look at the light blue bars. Those are for all of their national EBPs. So even when you have care management entities, if you're doing wraparound, it takes a lot longer to get through your implementation phases than other evidence-based practices, which is not surprising. Wraparound is essentially like implementing systems of care. It takes a lot longer, it's much more complex. And then, perhaps most important, the CMHC states across all of our domains and total scores on the COMET, the coaching measure of effective teams, fidelity and skill attainment was much higher, significantly higher for the states that organized using care management entities. So the points here to wrap up, system and program context matters a lot. And we were able to show that because we collected data at the outer context, at the organizational level, about implementation, the implementation process. And so administrative and fiscal structures associated with CMEs promoted more complete implementation, faster completion, and better adherence to wraparound. All right, so I'm wrapping up. I don't know if there's any questions. I heard there's not many, so. Here's our main take-home points. Implementation is multi-level and phased. Feel bad for our interpreter. I'm talking so fast here. Measures of implementation have to account for phases and time and level, and we can do that. Although fidelity and outcomes get the most attention, system and organizational measurement is critically important, and it's doable. There are existing measures, or you can create your own. And measurement at these levels can inform your planning, your selection of programs or strategies. You can use it for CQI, and like you just saw, we can use it for really important research and evaluation, which is really fun. So I'll fill in references when this goes up on the website. Sorry about that. And there's my email. I really do welcome folks to email me with any kind of questions. If folks are looking for some of those measures that we referenced, email me and I'll let you know where to find them. I wouldn't have gone so far over, Tony, but I heard that there aren't many other questions. Do you have any?
So we had one come in that said, I would love to get more written material on system level measures and accountability that needs to be in place for system reform, but that sounds like something that you could email Eric for. He may be able to provide that.
Yeah, email me. And if you're talking about, kids' behavioral health system reform, we've got, I think, there's measures of system of care implementation that Beth Stroll has developed. I think our wraparound measures are pretty appropriate. And if you're talking about EBPs more in general, there are measures at the state level, such as the State Health Authority Yardstick or the SHAE, and a ton of other ones that have been developed in the last 10 years. So yeah, write me and tell me exactly what you're looking for, and I can help send you to the right places. Anything else, Tony?
I don't know if we have time for any more questions, so I think we're gonna wrap up there.
Well, if there's any good ones, send them to me, or people can email me. I was told that we didn't have any, so I would have stopped earlier if I'd known that. But
no, we don't have any. I have one, but it's going to take way more than a minute to answer. So,
all right. Well, feel free to send me those questions to this email, and yeah, that's my my Twitter there at Eric J. Bruns, and my email ebruns@uw.edu. It's fun putting this together and doing this session of Training Institutes Live. So at this point, I think I stopped sharing my screen, correct?
So
no, I don't. All right. Well, I'll put it back.
So thank you, Eric, for sharing your expertise and strategies with us today. And thank you to all of you for joining us for this segment of the Training Institutes Live. We hope that you take advantage of the wellness break before you join the next set of workshops that will begin at 3:30. If you have not registered for one of the 2 workshops beginning at 3:30, it is not too late. The links for the wellness break and the 3:30 workshops are in Ideas at the Institute. The link is being posted now in the chat. You can also register for future workshops using this link. Also, we would very much appreciate you taking a few minutes to complete the evaluation for this workshop using the link that's posted in the chat. Your feedback will help us shape the upcoming workshops in this series. Again, thank you for joining us today, and we look forward to seeing you again after the break and the first Thursday of every month for Training Institutes Live.
Thanks, everybody.
Thanks.